So we already finished renin-angiotensin aldosterone system. Now, there's a difference between ADH and aldosterone. They're not the same. Aldosterone affects both reabsorption of sodium and water. Antidiuretic hormone only affects water. Are we clear? Okay, so this will only command nephrons to reabsorb water, does not directly affect sodium. However, a big however, if the kidneys reabsorb water only, leaving sodium in the blood, what will happen to the sodium levels? It's going to increase. Vice versa. If a patient does not have enough antidiuretic hormone, therefore it does not reabsorb water at all, leaving water in the bloodstream, what will happen to the sodium level? Okay, so does it directly affect sodium? No. Indirectly, however, it can affect sodium. Are we clear?
Yeah.
We'll discuss more of that when we get to diabetes insipidus and SIADH. Natriuretic peptides. I can say our bodies are more effective with managing dehydration than it is with fluid overload. Because how many have we discussed so far that will react to dehydration? Renin-angiotensin aldosterone system, ADH, and we have sympathetic also, which is not in this chapter. There's only one for fluid overload, which is the release of natriuretic peptides. There are two types. We have A and B, B-type natriuretic peptides. We say A, this comes from the atria, the atria of the heart. B comes from the ventricles of the heart. The name is, it's named after the brain because that was where initially they thought it came from. But since they discovered it came from ventricles, they never changed the name. So it stayed BNP. But anyway, between the two, the BNP is the more reliable indicator. Because which one is more efficient, the atria or the ventricles? The ventricles, really, that is what most matters, right? Okay, anyway, so what is BNP? BNP is released by the ventricles of the heart in response to stretching of the muscles of the ventricles. Now, what could you imagine will cause stretching of the walls of the ventricles? Increased or decreased blood volume? Increased blood volume. So therefore, what condition could it be that will increase blood volume in the ventricles? Any fluid overload, right? Including heart failure. So in response, the ventricles will release natriuretic peptides because this thing has two effects. One, it has the effects opposite of aldosterone. So instead of causing vasoconstriction, this will cause vasodilation. Instead of conserving or reabsorbing sodium and water, this will cause diuresis. Okay, so instead of reabsorbing water and sodium, this thing will cause diuresis. So what will this do to fluid status? It will decrease fluid volume. Okay, so this is the only response by the body to fluid overload. Very inefficient, right? We're again more efficient with deficit, but when it comes to fluid overload, this is it. There's no other mechanism of decreasing fluid volume except maybe decreasing antidiuretic hormone release, but that's about it. So therefore, since this is only released by the ventricles, is it a reliable indicator of heart failure? Yes. In fact, this is the sole diagnostic, laboratory-wise, this is the sole diagnostic test we use for both diagnosing heart failure and also evaluating response to therapy. Let's say, are we treating the heart failure enough? All based on BNP. So BNP levels rise, that's heart failure. If it drops, then it's improving, right? So we use it as a basis of, are we giving enough diuretics? Are we doing enough fluid restriction? You know, is the therapy adequate? You can disregard the C type. It's not really clinically relevant. Okay, so let's go now to the two problems really quick. This won't take long because we discussed the indicators already. So hypovolemia or fluid deficit, dehydration, however you want to call it, there is not enough fluid in the body. We will not discuss the causes because there's a lot, and the management for each cause is discussed in different chapters. So for chapter 10, we'll skip through the causes, okay? Although there was a table on the previous page listing a few of the causes, to say diabetes insipidus, dehydration, shock, etc. And then the same thing also fluid overload. Manifestations, however, this one should be easy. So if I give you a select all or reply question and ask you either patient, which are signs and symptoms of dehydration, or vice versa, signs and symptoms of fluid overload, this is how you answer, right? So this is now, I'll give you BU and creatinine values, whether it's high or low, which one do you pick? Okay, so for dehydration, what will you pick, high or low? BU and creatinine. High, because this is equivalent to urine output, right? So the less urine output, then the higher the BU and creatinine will be. Urine output will be low. Okay. I won't put the electrolytes there because the problem with dehydration is the values of the potassium and sodium depends on the cause. Since the chapter does not discuss each particular cause, so I don't think it's fair because this will again qualify. See where it says hypokalemia and then hyperkalemia? Okay, so it really depends on what caused the deficit. So here, hypokalemia can occur if it's GI and renal losses, whereas it will be hyperkalemia if it's adrenal insufficiency, etc. See what I mean? Yeah. So it's not fair because now it'll be a long discussion. Plus, I'll have to discuss each particular cause for you to answer correctly. Does that make sense? Okay, so I won't put the electrolytes there on the manifestations because again, it's not fair. Okay. It'll just confuse you. So for sodium, potassium, you won't see it there, but you will see BU and creatinine, you will see urine output, you'll see the weight, you'll see hematocrit, hemoglobin, all right? So here are your signs and symptoms. We have table 10-4, one is for deficit, the other is for fluid overload, right? So right here, we will discuss CVP later when we get to heart failure. I'll discuss this briefly. What does central venous pressure mean? So table 10-4. But of course, it'll be more specific, okay? Let's say when I say weight loss, I'll probably put the patient's weight and then what is the patient's weight now? No, something like that. Data instead, meaning I won't interpret it for you. Okay, so I won't say BU and creatinine high. I'll say these actual BU and creatinine values. Same thing for the specific gravity. So I'll put the values there, say 1.032 or 1.001. Okay. So here's what we discussed on the first hour. Oliguria is again what? Less than 400. And what is anuria? Less than 100 per day. So how do we manage someone's deficient in fluid? So how do you fix it? Give them fluids, either by mouth or through IV. Okay. What type of solution? Well, it depends. So let's do one scenario. So let's say the patient's having nausea, vomiting, diarrhea, or let's say 16 times in the last hour. Okay? Crap themselves, 16 times nonstop. So what is the patient's blood pressure here? Low. And what do the cells look like? Okay, so how do you fix them? What type of solution will you give? Let's discuss. If you say hypotonic, where will this fluid go? Into the cells, right? The textbook said that. So this will go from put fluid from the ECF into the ICF, right? The blood pressure though is gonna be what? It's gonna be low, right? So blood pressure will be low, heart rate will be high. Okay. So therefore, what do we do with the blood pressure though? Because no matter how much hypotonic solution you give, where will the fluid go? Into the cells. However, the bloodstream remains depleted. So therefore, which one's more important? The priority is circulation, right? We're clear about the ABC, right? Airway, breathing, circulation. Doesn't say cells, right? It says circulation. So blood pressure is priority over the cells. Yeah, the cells need help, but we need to fix the blood pressure first. So what solution will the patient receive first? Isotonics. That's why I said earlier, my answer was qualified. Yes, right? Technically qualified, yes, hypotonic. But initially, the first 1 to 2 bags will be isotonic first. So the order will change. So give bolus first, okay? Maybe 1 or 2 hours, 1 liter, depending on the blood pressure. Blood pressure's close to normal, not really normal yet, meaning still under 90. Systolic, 90 millimeters of mercury systolic. So doctor may say, okay, give a second bag or maybe half a liter. Okay, give another half a liter. Then we'll see. Blood pressure is now normal. Okay, switch to half normal. You get it? Okay, so it will, it will depend. What is the patient's condition? Plus, you can see again, there's different causes of fluid volume deficit. Could be diabetes insipidus, could be the nausea, vomiting, diarrhea, could be blood loss, who knows, right? And of course, the discussion here in this part of the chapter is only for the dehydration. Are we clear? Yeah. Did it discuss managing diabetes insipidus? No. Or any other causes, burns, etc. No, right? So this is only discussing dehydration. That means will the patient also receive treatment for the cause? Yes, which is not discussed here. Are we clear? All right. So for any on the NCLEX, it will be integrated now though. So you won't just answer based on, oh, this is chapter 10. You can't do that anymore. It'll be a combination of chapters now because you now understand, let's say, this patient who is dehydrated, can they go into acute kidney injury? Yes, that's not discussed here. This is chapter 10. The AKI is a different chapter. Do you understand? Okay, so it's now integrated questions, right? So, but of course, they don't design textbooks like that. Textbooks are on, chapter by chapter. But it is important to realize that, okay? So that's why it says here, so the initial is isotonic, and then as soon as the patient becomes normotensive, meaning blood pressure is normal, then we can go with a hypotonic. Are we clear? Yeah. All right. Very good, children. How do we know our fluid replacement is enough? Only vitals? Okay, so whatever you assess prior, the skin, the weight, the labs, okay, the patient's vital signs, that's your basis again. So is it just one time, let's say initial, okay, high five the doctor, oh, yeah, fluid volume deficit, just give fluids, and then that's it? What now? Oh, okay, so you reassess constantly. You monitor. Are we giving enough or are we giving too much? Can we possibly give too much? Yes, nobody's paying attention. This will overload the patient. Now we have a different problem. So now let's go to so here are the solutions which we discussed already earlier. We kind of just went ahead. So table 10-5 tells you the indications. Okay, what's in the solutions and what are they for? The rest of the nursing management have to do, we'll discuss monitoring, which we already did on the first hour. Okay, so these are again some of the examples or causes that could lead to fluid volume deficit, no diarrhea, vomiting, or any adrenal or pituitary problems or trauma. The least reliable indicator is the skin, except if your patient is an infant. But this is adult med surg, so we'll never talk about infants here. Because a 90-year-old skin, does it look any different whether they're normal, deficit, or overload? No, they look the same. They look very, very fragile. Yeah. So is it reliable? Like will you base it on the doctor, the skin still very wrinkly. It was wrinkly. Eh, no matter what you do, it's gonna be wrinkly. So it's the least reliable indicator, except in a younger patient, as already mentioned. Of course, others are the mucous membrane, which is close to the skin, so it's also not very reliable. Okay? So we maintain with the weight, laboratory, and vital signs. So we already discussed this, right? So the 1 liter, 1 kilogram, and the 1 pound, 500 ml. Okay, are we clear? All right, so I didn't pull that out of the thin air. Okay, so it's based on your textbook. And we discussed the urine concentration, serum osmolarity as well. And like I said, we will discuss hemodynamic monitoring, which is where that CBP item earlier. We'll discuss that when we get to heart failure, which is next week. Prevention, of course, you have to know what are the causes and then implement your prevention. Of course, the patient, even if they didn't come in with those causes mentioned earlier, they can still experience fluid and electrolyte problems while in the hospital because simply of the change in the environment and the conditions. Let's say, can they get up and go to the fridge and help themselves to whatever is in the staff, the patient refrigerator? No, they are at the mercy of the staff, right? And the kitchen. Say whatever the kitchen brings up, although we do ask them, we give them menu choice. Okay, they don't go with what do you want today? No, they give you the menu. Here's the menu today. What do you got? Okay, can't be more than $25. That's the allotment, like prison. Like that's it. Your last meal can't be more than $25. So they can't ask for a tomahawk steak. Okay, the state doesn't have that budget. Anyway, you know what I mean. Okay. So IV fluids again, and the management, of course, is to treat the underlying cause of the dehydration. And for evaluation, of course, we need to know when to stop, right? So as soon as the labs are normal and the cause has been corrected, then patients considered treated. Fluid overload. So this is the opposite. Again, the causes, countless causes. We'll do a few examples after this one. Manifestation, so opposite the dehydration. So what will be the blood pressure? High. Heart rate will be? It probably will remain high because now the patient has higher fluid volume, so the workload increases. What about the weight? Okay. The BUN creatinine. Hematocrit. Urine output. Lung sounds. What's the lung sounds in dehydration? So no air going in? Clear, right? Okay, clear or normal. What happens to the veins, like the neck or hand veins? Okay, all right. And they will be what in dehydration? All right, very good, children. So they're listed here. And also remember table 10-4, the previous page? Okay, so it was side by side, right? Or not, like up and down rather. So first column was the dehydration, and then fluid overload was on the second row. So here are some laboratories again. So we already told me what they are. So prepare for select all that apply type questions, or it could be you know, categorization. You'll drag and drop stuff. So I'll give you a question wherein it's 2 columns, and then the instructions will be, okay, drag the findings, okay, to either fluid volume deficit or fluid volume overload. Could be signs and symptoms, or it could be treatment. Okay, what are the interventions? Drag the interventions. Okay, where will you give fluids? Okay, here on dehydration. Where will you give the fluid restriction? Under fluid overload. Where will you give diuretics? Fluid overload. Okay, things like that. So it's exams are fun. I like this. Question? Yes. Both. From the earth. Okay, diuretics if appropriate. Now, not all patients with fluid overload will be given diuretics because what will diuretics do to the electrolytes? It will drop everything, right? So you're familiar with potassium, but if you read the drug book, does it really only lower potassium? Lowers everything. Calcium, sodium will all be low, right? So the patient won't just lose water, okay? It will include electrolytes. So as far as the decision to use which diuretic or how much diuretic depends on what is the underlying cause of the fluid overload. But it's an option, okay? So diuretics are an option. What about fluid restriction? Yes. Dialysis is an option, especially if the patient's kidneys are not working, which is the cause of the fluid overload. We'll discuss dialysis next week. Nutrition therapy, so fluid overload, what will you restrict? And sodium too, right? Okay, so sodium, there are different levels of sodium restriction. Here's a warning here with salt substitutes. Now, yeah, we can use salt substitutes because will the patient eat if there's no sodium in it? No taste, no salty taste? No, nobody's gonna eat that. So we use salt substitutes, okay, or any flavoring like Mrs. Dash, for instance. However, here's a warning. Most salt substitutes, especially the cheap ones, $1 to $2 ones, contain potassium because instead of sodium, they'll use potassium because the taste is the same. So is this safe? No, especially if the patient has heart or kidney problems. You can't encourage salt substitutes, which are again made of salt substitutes. There are potassium-free salt substitutes, but they cost like $7, $8. So that's like 6, 7 times more expensive than. I mean, would you spend that much on flavoring? Well, for you, because you guys have money, but think of because these patients are usually retired patients. Okay, so they receive, I don't know, 1,000 a month, $1,200, $1,500 a month on Social Security. Okay, so these patients have limited funds. Okay, so you're still in your productive years now, but remember most patients in the hospital are on Social Security now. Okay, so you have to consider that. Okay, so don't assume, oh yeah, I have, like you always have extra money in the bank. Maybe these people, no. Okay, sometimes they're short, right? Or most of the time they're short. So you have to choose between, it matters. These $10 matter a lot to these folks. Okay. Okay, management, again, same thing as dehydration. So you still monitor because can we have the other problem now? Because if you continue the diuresis, the fluid restriction, can you go dehydration? Yeah. Yes, you'll have the opposite problem now. And so always monitor labs and report accordingly. If let's say you have the other problem now, so you tell the doctor, then now we'll have to treat them for dehydration again. Especially if you're giving IV fluids. Now going back to, okay, we already discussed that, right? Okay, 1 liter for 1 kilogram. Now, with potassium again, 80% of our, this is regards to, because you may be giving potassium replacement here, because out of all the electrolytes, this is the most common deficiency. So you'll have more frequent problems with potassium with as opposed to sodium. Okay, so most patients will have either too high potassium or low potassium. Now, in that case, if it's low potassium and the doctor orders potassium replacement either by mouth or IV, please check first kidney function. Are we clear? Because 80% of your potassium is excreted through the urine, through the kidneys. So therefore, plus remember again, if the patient's dehydrated, are they in AKI? Possibly. Yes, that occurs almost together. Okay, dehydrated patients are always in acute kidney injury. Therefore, are the kidneys working? Not momentarily, no. For several hours, it will not work. So therefore, can it get rid of potassium? No. So always be careful before carrying out orders. Okay, keep it in mind. Potassium replacement, you have 4 or 5 bags to hang, 1 bag every hour. Check your patient's potassium, the kidney function first. Are we clear? Check that kidney. Is it capable of eliminating that potassium? Because you could have the other problem now. Instead of hypo, you could have hyperkalemia, which is equally lethal, equally fatal. And of course, for edema, so we have their fluid restriction and diuretics, right? And then, of course, elevation of the affected extremity, okay? Because especially if it's dependent edema. Electrolyte imbalances, will only discuss 2, potassium and sodium only. Let's start with sodium. I won't discuss the causes because again, there's a long list and they're not discussed here anyway. And the treatment for each one, for each hyponatremia or hypernatremia depends on the cause. So for sodium imbalances, I'm only testing signs and symptoms because the interventions vary depending on the particular cause, and they're in several chapters. So for exam 1, I'm only discussing signs and symptoms, okay? So there are always 2 problems with electrolyte imbalances. Either you have too much or not enough. Let's start with deficit. So the manifestations are already here. So table 10-6 already organized for you. So if the patient's sodium is low, these are your manifestations. So keep in mind to help you remember, electrolytes excite cells, correct? Yeah. So they're either positive or negatively charged. They have one job, which is to excite cells, stimulate cells to function. So when we say sodium deficit, where is this low in? Intracellularly or extracellularly? Outside of the cell. Extra, because the specimen we use to determine this is blood, right? Which is extracellular. So you drew blood, you saw sodium is low. So you know it's low in the bloodstream. So therefore, look at the resulting manifestations. So if it's going to excite cells, if it's low, is it exciting the GI tract? So therefore, what will happen to peristalsis? So therefore, will the patient have any appetite? Will they pass any gas? No, as a result, they'll have anorexia, nausea, vomiting. Sodium's low. So therefore, what happens to the cells in the brain? Because now imbalance, there's what happens to the bloodstream here? Hypotonic, correct? So you have a hypotonic blood sample because the sodium is low. So therefore, where will fluid go? Into the intercellular compartment, causing cerebral edema, headache, lethargy, dizziness, confusion. Make sense? Okay. So in severe cases, these patients can go into seizures, okay? Especially if your sodium is like less than 120, okay? Because it's 135 to 145, right? So 120 and less, we institute seizure precautions. That patient will go into seizure, right? If it's critically low. One general rule for low sodium is we won't give the patient regular fluids. We will restrict the patients. Most of the time, that will be enough to raise it. Okay? Fluid restriction alone, regardless of the cost. That's the one thing common in all of them. However, in some cases, again, depending, this is what I'm saying, depending on the cost, the patient will receive IV infusions. The patient may receive, very rarely do we do hypertonic saline, but we can do normal saline. However, the concern again is cerebral edema. Okay, so most of the time it's fluid restriction with a few exceptions. That's why, again, I'm not testing the cost because it'll confuse you, okay? Because it really depends on the cost of the hyponatremia. Hypernatremia. So this is now too much sodium. These are your manifestations. So either low or high sodium, will end in seizures. So therefore, what have you noticed in sodium imbalances? Which body system is affected? Usually neuro, right? Okay, so more on neuro. Yeah, it affects the GI also and the muscles, but your your majority concerns is neuro. All right, that's it. So I said I'm only doing manifestations. Okay, I'm not testing causes, not testing interventions. All right, let's go to potassium. This one, I'll do both signs and symptoms and treatment because regardless of the cause, interventions are the same. It doesn't make a difference. Let's start with deficit. Manifestations are the following. It affects the entire body. There's no cell that is not affected. There's no body system not affected by potassium. But which one is the most critical? Cardiac. Okay, cardiac, obviously. Because is it life-threatening to have vomiting, muscle weakness? Not really, right? So it's really the cardiac problems. Of course, the muscle weakness can also involve the diaphragm. I mean, don't get me wrong, because the diaphragm is a muscle, correct? It will result in diaphragmatic weakness. So respiratory effort will be affected by low potassium. But your concern again is the cardiac. That's a priority. Whereas with excess, same, if you look at the pattern, whether it's low or high, we're concerned with cardiac problems. And although with the GI, it's opposite. So here in deficit, you have low peristalsis, you got constipation, nausea, vomiting, then you have diarrhea right here and cramps in hyperkalemia. For now, I won't test you on the ECGs for now. But for exam 3, I can because we will finish module 8, which is the arrhythmias already by module 8. So that's for exam 3. Let's go to interventions now. So I won't do the causes, only signs and symptoms, and then interventions. Most common cause of hypokalemia is fluid loss. Okay. Patient has any of the causes of dehydration, then that can lead to hypokalemia. So here are our interventions. So in dehydration, what did you treat the patient with? Dehydration? You gave them fluids, right? Fluids, you know, IV or PO. Patient has low potassium, so how do you treat it? You give them potassium also either by mouth or IV. The decision whether by mouth or IV depends on two factors: the patient's level of consciousness, are they able to swallow? Okay. And also the severity. How low is the potassium? If it's really critically low, meaning under 3, of course, we will have to give it IV because no amount of pills can fix that fast enough. Okay. The problem with potassium is there's a limit to how much we can give every hour. That's why it's very crucial to prevent it in the first place. But here we are, the patient is hypokalemic. It's dangerous to replace it too fast. So it will take hours, sometimes days to correct this. Sometimes, let's say you gave 5, 6 bags on your shift and then you went home. Next thing you know, you come back the next day. Oh, the day shift also give just as much. Okay, so it's common like that, like especially if the patient's not eating, or elderly patient from a nursing home not eating. Of course, they'll have hypokalemia. Okay, so it's hard. It's not easy to correct because you are limited by how much you can give every hour. There's a limit. You give any more, that's equivalent to a lethal injection. Okay, so we're in a hospital, not in some prison. Okay, so we're not in. Is there death penalty in New York? No, right? Yeah, so we're not, in those states. Okay? So that's the only way the only place you give that much potassium is if you're trying to execute somebody. So we'll skip again the ECG changes for now. Here's a warning. This will be in relation to heart failure, which we'll discuss next week. Now, patients with hypokalemia and they're taking digoxin. Now, the drug digoxin or digitalis enters the cardiac cells via the sodium-potassium pump. Simply put, it cannot enter the cardiac cell, unless there's enough potassium. So therefore, low potassium will do what to the drug levels in the blood? Toxic. It cannot enter the cell. It will remain in the bloodstream. We'll discuss signs and symptoms when we get to heart failure. But here's the consequence, okay? So potassium plus the problem there is, are heart failure patients on diuretics? Yeah, they're taking diuretics, which cause what to the potassium levels? It decreases it. Plus they're on digoxin, perfect combination, right? Taking digoxin, taking diuretics, of course there will be hypokalemia. Of course they'll be at risk for toxicity. All right. Management. So again, PO or IV. So PO is okay. You can give 40 to 60 per day. So that's every 2 to 4 hours you give that. That's okay by mouth. But what if the patient is not able to take it by mouth? So we're stuck with IV now. The limit for the IV is 10 milliequivalents per hour. There's no other route. It's only given oral, which includes enteral, meaning you can give it through a PEG tube or G tube, but it's only oral and IV. There's no IM or sub-Q route. Are we clear? You only give it by oral or IV. You have to be really stupid in order to kill someone with IV potassium, okay? Or you have to be a psychopath. Now, in the first place, nurses do not have access to potassium at all. During my time when I graduated or when I was in school, it was everywhere. And you can't believe what we did at that time. We had we had multi-dose vials of everything. Okay, so morphine, Demerol, name it. They're all in the cabinet. There's no medication dispensing machine. There's no cow to speak of. Okay, they're in a cabinet. So we all rely on the honesty of each other. Okay. So potassium is on the cabinet right next to saline. They look the same. They're clear plastic vials with a green label. The only difference is this one says 0.9% NaCl. This one says KCl. That's it. So someone grabs it. There is no scanner, right? There was no scanner. All we did was, okay, well, this is a drug. And then, so could we have made a mistake? Yes, very dangerous. I wondered how we didn't, we should have killed more people than we actually did. It's very unsafe. So here we are today, modern day. Obviously, somebody died, right? Because of that careless practice. So now we have, that's why I'm saying you have to be extreme, you have to be a psychopath, you're a killer. Or you're just plainly stupid. It's for you to make a mistake. Okay. We don't have access, like I said. It's only found in two places, pharmacy and the emergency room. Obviously, emergency room, they need it in emergencies, but no other place. ICU doesn't have it. The OR doesn't have it. All right. Where are the only two places you can get potassium? Pharmacy. And the ER. That's it. Okay. Nowhere else. Because we know, people make mistakes. Okay. So we don't want to give the patient, the people, the nurses, the opportunity to make that mistake. All right. Okay, so priority though, you'll have the list of orders. You'll have okay, you can have both. It's not just one or the other. You can have PO orders, okay, 40 times 4 doses, for instance, 2 hours apart. And you can also have IV at the same time, IV 10 milliequivalents times 6 doses or however many doses. And then you have placed on a cardiac monitor. Which one will you carry out first? Say you have PO potassium, IV potassium, and then cardiac monitor. Right, cardiac monitor first. Because again, can we replace potassium fast enough? It'll take days. Okay, depending on the level. It's minor, let's say 3.4, 3.3. We can do that in a few hours. But it's less than that, 3.1 and below. That'll take days to replace. You can't do anything about it. You're restricted with the limit because you can only give 10 IV. That's it. No more than that. So therefore, we are helpless, right? So can the patient die in between now and then when we fix it? Yeah. Yes. So we need to know, right? If they're about to die. So we put them on a cardiac monitor. So we look at the cardiac rhythm constantly until it's corrected. That way, if they throw a dysrhythmia, we can treat the dysrhythmia, okay, until we fix the potassium level. Are we clear? So what's the priority? Cardiac monitoring. Don't choose the IV or the PO potassium because that's basically, I'm not saying it's useless. It's not going to fix the problem. All right? We're helpless. We have to place them on a cardiac monitor first and then start giving the PO or IV. Do we understand each other? Yes. So again, it's impossible to correct in a short time. It'll take like a lifetime. Okay, if you count the hours, no, your shift is not going to be enough. It'll carry on to the next couple shifts. So prevention is best. We'll discuss this when we get to DKA. Okay, because one of the treatments but that's under hyper. I'll mention that under hyper. So this is hypo. So if the patient is on, let's say the example I gave you earlier, they're on diuretics and taking digoxin. So how do you prevent it? You know they're going to lose potassium. Okay, encourage them to eat high potassium foods. And what are they? So on the exam question, what will I do? Okay, so these are the choices I'll put there. Probably not these exact words. Like I won't put citrus fruits. I'll put what? Oranges. Okay. I'll probably not put grapefruit because the patients usually have, calcium channel blockers. So they'll say no grapefruit. Okay. I guarantee though, I won't put bananas. I'm sick and tired of bananas. Because I don't eat bananas. I eat something else. So oral again, and then for IB, so here's the warning. Now, I know this says here 20 ml per hour, but this is referring to the urine output. Okay. So a decrease in urine volume to less than 20 ml per hour, is it safe again to give potassium? Because what is this evidence of? Kidney injury. Kidneys aren't working. So is it safe to give potassium? No, because you can have hyperkalemia as a result. Oh, another warning. You never give it IV push unless again you are working at some, death row. Say so you're, but nurses don't do this, by the way. Only a doctor can give IV push potassium when they execute somebody. It's only a doctor, okay? Nurses, it's against our ethics, okay? Because we when we take the pledge, we say I pledge to kill, inmates, right? You don't do that, right? So we don't do that. So only a doctor can do that. And again, no IM, no sub-Q. Okay. Potassium, therefore, since it's not given IV push, it's always diluted. Okay. So the smallest dilution is 10 MEQs in 100 ml of, I think it's saline or dextrose. I'm not sure. But it's only 10 milliequivalents. Okay. All right, so we already discussed that renal function should be monitored throughout potassium replacement. Any questions? All right, let's go straight to excess now. Hyperkalemia. So now we have too much potassium. There are several ways to treat this, but just like in hypokalemia, it can't be corrected quickly. However, not as bad as hypo. Hypo will take hours, days to correct. Hyperkalemia can take a couple hours. Okay. But since it's a couple hours, it's 2 hours or more, what can happen between now and 2 hours later? They could also throw a fatal dysrhythmia. So what is the most important intervention then? Monitor first. Okay, so place the monitor leads, put them on a cardiac monitor, and then implement the treatment. Okay, there are 4 to 5 options to lower it. The goal is either to shift it, meaning take it out of the bloodstream, which is fastest. However, that option is temporary. Again, two goals here. If you can't get rid of it, at least put it somewhere else. Okay, so we will shift it out of the bloodstream, put it somewhere else, usually in the cells, and or eliminate it. Okay, so 2 goals. Let's look at the, I'll go to the oh, by the way, again, I won't do the cost, but just be aware that hyperkalemia is quite common in septic patients. Patients who are dying, in shock, for instance, sepsis, anytime they have an acidotic condition, say even in kidney failure, sepsis. So any of those severe conditions, because cells start to die and the potassium actually came from those dead cells, right? So whenever a cell dies, they spill out potassium. Okay, so don't think that where did this potassium actually come from? Did they like eat a whole container van of bananas? No, this came from their cells. Okay, so the cells died, which is what happens when you have an infection, COVID, for instance, sepsis, lots of cells die there. So this is where the potassium came from. Okay, so the acidosis led to the hyperkalemia. All right, don't think that, oh, this is excess, patient eats bananas every day. No, you have to eat a ton of bananas to cause hyperkalemia. Okay? It's not easy. It's, one banana is not really that much potassium. Okay, so you need to eat like a whole grocery, display of bananas for you to go into hyperkalemia. Another reason is, of course, acute kidney injury, okay, or chronic kidney disease. No kidneys, then of course you can't manage potassium levels. So let's go to manifestations. We looked at table 10-6. So let's go to management now. Okay, so the decision to either shift or eliminate it depends again on the level. How bad is the hyperkalemia? So do we want it to lower it fast? Of course, we would want to, but considering the cause, let's say if the cause is kidney injury, can we fix that kidney injury fast? No. So if the potassium is, let's say, 9, 8, normal is 5.5. Okay, that's the higher limit. So it's now 8, 9. Of course, we need dialysis there. Okay, emergent dialysis. There's no way you can fix that without dialysis. So cardiac monitor and then stat dialysis. So they insert a dialysis catheter and then immediately start dialyzing. In less urgent conditions like that, you have an option to here in non-acute situations. Of course, you can restrict potassium. And then there's this oral resin. So if you have mild hyperkalemia, let's say it's 6 or 5.7. So you can do potassium excreting resin. So the most common in most hospitals is Kayexalate, but that's brand name. So the generic is sodium polystyrene sulfonate, SPS. That is the fastest option for mild hypokalemia. The problem here is this can take 2 hours to work. This will eliminate potassium, okay, through the GI tract. So this will promote bowel movement, right? So patient takes this by mouth, or the patient can't take it by mouth, no unconscious, no feeding tube, you can give it through an enema. Okay, you put it in an enema bag with some fluids, give it will cause a bowel movement. Okay, so the potassium will be excreted through the GI tract instead of the urine. Okay, remember it's 80% through the urine, right? But most again, the most common cause is either the patient is really sick, right? Septic or in acute kidney injury. So kidneys aren't available. So we go to the GI tract. So this will eliminate it. Again, how long does it take though? So 2 hours. So this is only applicable for mild hyperkalemia. The other drug not mentioned here is Lokelma, which is basically works similar to SPS. So either Lokelma, which is more desirable to drink because it's orange flavor. This thing has a really nasty taste. I don't know how to describe it. I tried tasting it. No, just curious. I put a few drops in the cup. And I was like, I'm not drinking this. Okay. So that's an option for mild. However, oh, by the way, there's a warning here. So if the patient has any GI problems, is this an option? No. So patient is post-op and do you have peristalsis there? No. Okay, so here's another one, Patiromer Sorbitex. So whichever one the NCLEX uses, but these are all oral and rectal options. Okay, oral, and when I say rectal, that's to an enema. So Lokelma we can't give through an enema, it's oral. So Lokelma, SPS, or this one is modern, Patiromer Sorbitex calcium. Okay, so that's the same thing, excrete it through the GI tract. Yes. Lokelma, Lokelma, Lokelma. I don't know the generic though, because it's also new, relatively new. So I'll find out. You know what? Let's find out right now.
Is that a medication?
Oh, if not for me, on the NCLEX. Okay, so sodium, zirconium, cyclosilicate, SZC. Sodium, zirconium, cyclosilicate. But I'm only testing what's on your textbook. Okay, so textbooks has SPS, sodium glycerin sulfonate, and you got patiromer. Clear? All right, here's patiromer. Okay, so if it's severe, we have other options. So we're talking over 6, 7, and beyond. Okay, so that's moderate to severe hyperkalemia. We have to eliminate it fast. But again, the elimination option takes 2 hours, right? The elimination option were the patiromer and the SPS, which is by mouth or through an enema, which take 2 hours. So if we want to lower it fast, the only other option is to shift it. Clear? Now, take note that shifting it is temporary. Okay? It will buy you time though, because what is the effectiveness time, effect time for the elimination option, the Resence? 2 hours. So these options will buy you 2 hours. So which one you give first? This one or the 2 hour? This one first, because this will shift it right away. And then you follow with the SPS, which will finish the job off. Are we clear? Correct, yeah. So by the time these options, these short-term options wear off, the other elimination option should have kicked in already. Are we clear? All right. So what are your short-term temporary fixes, which is to shift? One is to give IV calcium gluconate. Now, take note, you probably won't get one order. You'll have multiple, all right? Especially if the levels are 6 over 6 or 7, you'll get several doses. Okay, so you'll get calcium gluconate, plus you'll also have dextrose with insulin, which is the other option. So here it explains here why IV calcium gluconate will lower potassium. No, sorry, there's an exchange here, etc. So just read the detail. Now let's go to the other option. So sodium bicarb. Right, again, another temporary solution. So this will alkalinize plasma, shift potassium into cells, blah, blah, blah. Here's the third option, which is regular insulin with dextrose. Take note, this option is and. Are we clear? Can you give one or the other? No, you cannot do that. You have to give both, because what will happen if you give only regular insulin? Yes.
The body will make up.
Well, no. IV administration, this will lower the potassium. However, what will also drop? Sugar will also drop. So you're saving the patient from hyperkalemia, but you'll kill them with hypoglycemia. So it has to be given with a dextrose solution. Are we clear? All right, so never one, okay? It's always given 2, okay? So when on the MAR though, it would be 2 separate orders on the MAR, but you give them together. Are we clear? All right. Just so you know, you don't end up killing somebody, right? So you give both, okay? So when you have hyperkalemia, expect these orders. A severe hyperkalemia, you'll see IV calcium gluconate, IV sodium bicarb, IV dextrose with the IV regular insulin. Now, the only type of insulin given for hyperkalemia is regular. Okay, because no other IV, insulin can be given IV, only regular. The others are always subcutaneous. So look at how fast it is. Within 30 minutes, starts lowering the potassium. Okay, so therefore, if you give them, so most of them, have a 30-minute here, all say 30 minutes, right? So by that time, it should be lowering, and then the patient should have full effective control after 2 hours, given the other excretion options. Okay. Now this is quite fast. Okay, so when we have patients like these, you need to give these stat, right? It's not something, oh yeah, I'll get to it later. No, give it now, right? There's a reason why these are ordered. This case is dangerous. I don't really get the question, but here it is. So let's say I get all these orders, right? So which one do I carry out first? Cardiac monitor, correct? With the monitor. And then which one do I give?
The one that you buy.
The resin or these options right here? These three first. So IV calcium gluconate, IV sodium bicarb, IV regular insulin with dextrose. Okay. And then there's a this one will also work, but I wouldn't do this first. So another option is albuterol, nebulizer. Okay, so you can give albuterol, and this is the the benefit. So you can give that. However, yeah, because it's a beta-2 agonist, so therefore it'll cause, it's a sympathomimetic drug, so it'll cause tachycardia. So you can give this through a nebulizer, okay? But I wouldn't do this option first. Okay, I will go with the other three first before the nebulizer. So throughout, until you fix the problem, you'll have to monitor the patient closely, okay? Especially the kidney function.
What about waste?